Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to talk about another 3 fellowship Vivas. So before we dive into these Vivas, welcome Maddie. How are you?
Yeah, I'm good. Good, can't complain. Getting towards the end of the year, looking forward to Christmas. How about you?
Yeah, that's correct. And actually, after the lockdown is open now, we can go outdoors and enjoy the meal and play sports. So it's great fun. So yeah, can't complain. So let's begin with the first scenario for today. So you have been called to assist at a resuscitation of a 27-year-old patient in cardiac arrest on the general ward of your hospital. The patient is on the floor with the surgical JMO attempting ventilation with the bag and mask and a nurse performing chest compressions. The patient has super morbid obesity with a BMI of more than 60 kilogram per meter square. So what will be your approach and what are the key issues that you would consider in performing resuscitation in these circumstances?
So I think this is a very difficult situation due to the patient's body habitus, his location on the ward and on the floor, and the small amount of staffing present. My approach would be to confirm the arrest using the ALS algorithm with certain modifications given the logistics involved in his morbid obesity. So coming to just the routine ALS algorithm, it would involve first calling for extra help, especially given this gentleman's size and issues that are likely to come up with airway management, CPR and positioning. Allocating roles, hopefully airway is the most experienced operator. Ideally, we'd have CPR with 2 or 3 people switching to ensure effective CPR. Someone on defibrillator and drugs, and someone with IV access, a scribe and a team leader, but this will just be contingent on how many people are available. And then attaching the defibrillator and evaluating whether this is a shockable or non-shockable rhythm and continuing as per the ALS algorithm, getting IV access if not already present, which might need to be ultrasound guided or IO or early central access, and evaluating for reversible pathology, which would involve getting some further history exams and investigations. So in issues specific to this circumstance that are basically mainly patient-related and some staff and environment-related. The patient-related issues stem from his super morbid obesity and relate to both the assessment that's required and the ongoing management. So we can think about these issues using like an ABC approach initially, given this ALS situation. So in terms of an airway, he's likely to be a difficult bag valve mask and intubation in terms of his position and his obesity, especially since he's on the floor. This means that we do need a senior operator. We might need airway adjuncts, a video laryngoscope and D-blade and tidal on a bag valve mask to see if we're able to adequately oxygenate with the bag. If possible, we'll consider ramping to improve the position. Need to think in this case, because he's on the floor, about trauma and C-spine, but airway does take priority. An LMA in this situation might be unable to adequately oxygenate and ventilate him because of his size, but it's something that can be considered in the interim. And also he would be a difficult surgical airway and an increased risk of aspiration given his size. From a breathing point of view, physiologically in obesity, there's a decreased functional residual capacity, so more susceptible to hypoxia. There's increased CO2 production and increased ventilatory requirements. He'd be difficult to ventilate and have higher airway pressures, which don't necessarily correspond to the pressures within the lungs and the alveoli itself. And it'd be difficult to examine him to assess for breath sounds and to perform procedures such as chest drains or needle decompression if we identify something like a tension pneumothorax. From a circulatory point of view, physiologically, he'd be more prone to LV contractility issues, hypertension, peripheral vascular disease, and coronary artery disease. There's also difficulty assessing clinically, such as palpating pulses, obtaining a BP, the cuff size might be inadequate, assessing fluid status, and difficulties with IV and intra-arterial access. There's an increased risk of complications from IV access, and IO access may be impossible. And if there's something like a tamponade, it'd be difficult to perform a pericardial drain. It's also be difficult just logistically to perform effective CPR and sometimes in super morbid obesity. So we should consider a mechanical CPR device sometimes. In terms of assessing for potential reversible causes, any investigations will be difficult to perform, such as an X-ray, CT scan, blood test and an echo, given his body habitus. And potential reversible causes, it's difficult to identify and to provide treatment. So he's at increased risk of different causes that can precipitate hypoxia, such as venous thromboembolism, pulmonary hypertension, OSA, obesity, hyperventilation, and CO2 retention. In terms of toxins, he might have been on a lot of different medications. The optimal dosing for many of these drugs in obesity is unknown. If a clot is identified and we're thinking about either for anticoagulation, it's unclear what the adequate dose is in obesity. And as I've mentioned before, things like tamponade, tension pneumothorax, and hypovolemia are difficult to clinically assess and to treat. And he would be more prone to things like potentially hyperkalemia, because you can get a lot of pressure injuries with supermorbid obesity and a raised CK and rhabdomyolysis. From an environmental and staff perspective, we're in a situation on the ward where it's an unfamiliar environment. There are junior staff involved, which requires more assistance. The patient is on the floor, so it's going to be very difficult or impossible to get him back into bed. And we might consider if depending on logistics, if a hover hoist or something like that's available. And then for occupational and safety issues for the staff, there's increased risk of injury to the staff with manual handling of this patient.
Thanks, Maddie. So obviously you covered all the challenges quite comprehensively. So there are a couple of ways you can look at the scenario. So because it's a cardiac arrest scenario, you can either go via 4Hs and 4Ts, which are the causes of cardiac arrest, and then how will you troubleshoot each of them. Now, one of the things is about, especially with the P is higher likely in this case, and if it's a P, then giving the thrombolysis and deciding the dose of thrombolysis itself can be challenging, especially given the body weight is so high. And once you give thrombolysis, then you're almost committed to CPR for next 30 to 60 minutes, which is, again, quite challenging given that the body habitus and the location of the cardiac arrest. So there are a lot of different challenges, as you mentioned, and this scenario is definitely not an easy scenario to deal with. So let's move on to the next scenario for today. A 56-year-old male is brought to ED with trauma following an MVA. His initial blood tests reveal the following results. He has got raised AST up to 730, raised ALT up to 1030, mildly raised ALP up to 130, and increased GGT up to 94, with normal bilirubin, albumin, and normal INR. His blood sugar levels are 12.1. So what is your interpretation of these results, and how will you approach?
So this shows transaminitis with minimally obstructive features and no evidence of synthetic or long-term dysfunction. In this context, it's most likely secondary to a traumatic hepatic injury, but there are other potential causes, including acute derangement secondary to ischemic hepatitis, right heart dysfunction, or toxins consumed prior to the MVA, such as if you had alcoholic hepatitis or a paracetamol overdose, or chronic causes with a chronic LFT derangement, such as viral hepatitis, malignancy, fatty liver, and metabolic derangement, such as hemochromatosis and Wilson's disease, that weren't severe enough to cause synthetic dysfunction in this patient. So further assessment would involve having a comprehensive history exam and investigations to further elucidate this, and then also obviously considering the trauma during a primary and secondary survey and looking for further injuries.
Yeah, that's correct. So before you move on to that, you mentioned about the traumatic injury to liver. So how is hepatic trauma diagnosed?
So the liver is one of the most commonly injured solid organs in both blunt and penetrating abdominal trauma. And it's important to note that injuries to the chest are also often associated with significant liver injury because the liver can sit quite high in some patients. So clinically, patients may have right upper quadrant or shoulder tip pain, generalized abdominal pain, or chest wall tenderness. Depending on the extent of the injury, there may be hemodynamic instability or peritonism, and signs of injury to the lower chest or thoracoabdominal region should raise the index of suspicion of a hepatic injury. In terms of investigations, blood tests may show an abnormal liver function test, which especially involve elevation of the transaminases. A FAST scan may show free fluid in Morrison's pouch, a hypoechoic rim of subcapsular fluid, or intraperitoneal fluid around the liver. The definitive investigation is a CT scan with contrast, which can both define the grade of liver injury and identify other injuries. But in cases where the patient is too unstable for CT scan, the liver injury may be diagnosed during an exploratory laparotomy.
That's correct. So how are liver injuries graded?
So the degree of liver injury is graded from 1 to 5 using the AAST scale, the American Association for Surgery of Trauma Hepatic Injury Scale. This grade is based on the highest grade assessment made on imaging at operation or on pathological specimen. And the grades depend on the size of the hematoma, the depth of any laceration present, any vascular injury present, and the extent of parenchymal disruption. And there is a table which will be in the show notes.
Yes. So what are the basic principles of management of traumatic liver injury?
So the basic principles involve initial stabilization and resuscitation using the ATLS approach for primary and secondary survey to identify and manage life-threatening injuries, which would include adequate monitoring, IV access, investigations such as group and hold and imaging, and might include supportive treatment such as an ADT, fluid, blood product transfusion, aiming for hemostatic resuscitation. It then involves definitive management of the liver injury, which will depend on the hemodynamic stability of the patient and grade of injury. If the patient is hemodynamically unstable or there's any other indications for surgery, there's often an exploratory laparotomy, which aims to identify and control hemorrhage. This may initially be a damage control approach if the patient is very unstable, with packing of the liver, and then further attempts at definitive management when the patient is more stable. If the patient is hemodynamically stable and there's no indication for surgery, they're often closely observed and can be discharged home if there's a normal abdominal exam, stable hemoglobin for at least 24 hours, and no other injuries requiring hospital stay. Grade 1 and 2 liver injuries are often conservatively managed, but grade 3 and 4 are more likely to fail conservative management requiring surgery or interventional radiology for angioembolization. There's a low threshold for ICU admission for higher grade injuries, and embolization is considered if there's evidence of ongoing bleeding and a contrast blush seen on CT. In general, if it's a penetrating injury, there is a much lower threshold for operative management. So if it's something like a stab wound, where exploration of the wound is often required. And then further management involves monitoring and treating the complications that can result from hepatic trauma, which include delayed hemorrhage, hepatic abscess, hepatic necrosis, hepatic pseudoaneurysms, and biliary complications such as bile leak, bile peritonitis, or arteriobiliary or portobiliary fistulas causing hemobilia.
Thanks, Marty. So actually, I had exactly the same patient a couple of weeks ago, and he had pretty much all the complications listed here. In fact, he ended up in getting complications secondary to sepsis and required prolonged ICU stay. Finally, he managed to wean off everything and then got better and went home. So hepatic injuries can be quite tricky and challenging, and often the nutrition management also can be challenging because sometimes you won't be able to start enteral nutrition if there are associated other injuries, and then TPN can also affect with your liver functions. The management can get really complicated. Now, moving on to the third and final scenario, a 73-year-old female admitted following a collapse. She has a history of 3 days of anorexia, nausea, diarrhea, vomiting, and palpitations. She had a background history of heart failure, type 2 diabetes, AF, hypertension, COPD, and she's currently on furosemide, digoxin, amiodarone, metformin, aspirin, omeprazole, atorvastatin, and salbutamol inhaler. Her initial observations are heart rate of 51 beats per minute, blood pressure of 100 over 65 millimeters of mercury, respiratory rate of 30 per minute. Stats are around 93% on room air. And when you look at her bloods, blood result shows hemoglobin of 110 gram per liter, a white cell count of 14.9, platelets of 148, potassium of 6.5, and urea is 29.5, along with creatinine of 223. On gas, lactate is around 7.1, and the blood sugar level is 3.5. So what is your differential diagnosis here?
So this lady has evidence of shock with end organ impairment, concerned about digoxin toxicity given her bradycardia, vomiting, and acute kidney injury. This may be the primary cause of her presentation or secondary to another underlying pathology, including infection, such as septic shock with multi-organ impairment, which can be from multiple potential sources, gastroenteritis causing hypovolemia and accumulation of some of her medications, such as digoxin and metformin, cardiac pathology such as exacerbation of her underlying cardiac failure, a new myocardial ischemic event, complete heart block, or any other arrhythmia, respiratory causes such as PE with right heart failure, vascular causes such as an upper GI bleed or ischemic bowel given her lactate, neurological causes such as a subarachnoid hemorrhage, or drugs causing, such as digoxin toxicity, like I mentioned, or metformin toxicity.
Okay. Can you please outline the other investigation that you would order to help aid management?
So this would also be tailored by findings on history and exam, but these investigations would include bedside blood tests and imaging. Bedside tests would look for ECG for heart block, arrhythmias, or signs of digoxin toxicity, urinalysis and MCS for signs of infection, and an echo to evaluate cardiac function. And she's already had an ABG, but I'd also like to look at her gas exchange on that. From a blood test perspective, it involves blood cultures as part of a septic screen, looking at other markers of end organ function, such as the LFTs, coagulation profile, and fibrinogen, looking at a digoxin level, given her digoxin and AKI, and a troponin for ischemia. And imaging would involve chest X-ray, given that she's a bit hypoxic. And further imaging, such as a CT brain and CT abdomen, would depend on the other examination findings, but may be indicated.
Okay. So what are the ECG findings that are observed with acute digoxin toxicity?
So digoxin causes increased automaticity as well as an AV conduction block. So it can cause multiple ECG findings, which include both tachyarrhythmias and bradyarrhythmias. Tachyarrhythmias include bidirectional ventricular tachycardia, which is very specific for digoxin toxicity, but very rare. Accelerated junctional rhythms, multiple PVCs, paroxysmal atrial tachyarrhythmias with AV block, VT or VF. Bradyarrhythmias include AV blockade, SA node arrest, and AF with complete heart block and junctional or ventricular escape rhythms. So it's also important to note that the digoxin effect, which is sometimes referred to as like a reverse tick pattern, so ST depression in concave shape, biphasic inverted or flattened T waves, and a shortened QT interval, prolonged PR interval on an ECG is different to digoxin toxicity and is not a marker of digoxin toxicity.
And what factors increase the risk of digoxin toxicity?
So there are multiple factors, which include drugs, electrolyte, acid-base balance, elimination factors, and increased age. So drug factors are mainly through enhanced absorption, such as by macrolides or PPIs, or things that cause P-glycoprotein inhibition, which include things like verapamil and diltiazem, amiodarone, spironolactone, and quinidine. Electrolyte imbalances can also increase the risk, especially hypokalemia, hypomagnesemia, hypercalcemia. Acidosis and increased age can increase the risk of digoxin toxicity, and things that decrease the elimination, which include renal disease or dehydration, also increase the risk of digoxin toxicity.
Absolutely. And how will you manage digoxin toxicity, and what are the kind of specific indications of the drug that is used in managing digoxin toxicity?
So managing is obviously initial stabilization, appropriate monitoring, IV access, and admission to ICU, and then try and correct any of the factors that that increase of toxicity. So ensure adequate renal perfusion and blood pressure and electrolyte. The specific treatment or the antidote is digoxin immune antigen binding fragments, or which is called DigiBind or DigiFab in Australia, which is a monovalent immunoglobulin that has a much greater affinity for digoxin than the sodium-potassium ATPase receptor sites that digoxin normally binds to. By binding to digoxin, this prevents the digoxin from binding to this receptor and creates a concentration gradient from the intracellular to the extracellular space. That allows for more digoxin to be extracted from the intracellular space so that it can't bind to the receptors. And then the digoxin bound to this DigiFab is then renally excreted. So total digoxin levels will remain high with DigiFab as the level measures both the bound and the free digoxin. Consequently, measuring digoxin levels post-administration has no correlation with ongoing risk of toxicity. One vial of DigiFab will bind about 0.5 milligrams of digoxin, and the dose that you give depends on whether the toxicity is thought to be acute or chronic, whether the dose of ingestion is known, the serum digoxin concentration, and the weight of the patient. The indications for its use are treatment of known or strongly suspected life-threatening ventricular arrhythmias, progressive bradycardia, or second or third degree heart block unresponsive to atropine, and where measures other than withdrawal of digoxin and correction of electrolytes are thought to be necessary. But DigiFab has minimal side effects and no absolute contraindications except for hypersensitivity reactions. So these indications are quite flexible.
Thanks, Maddie. So that's the end of our all three Vivas for today. And I can't see there is any joke for today. So am I being exempt?
No, I do have one, but I don't know. I'm not that pleased with it. So yeah, but bear with me.
Okay, let's try.
Okay, you sound very unimpressed already. So why did Digoxin make an unreliable band conductor?
Is it something to do with the digibind?
No, he could not ensure a rhythmic beat.
Oh, I couldn't have got that one, but it's a good joke. Thanks, Maddie. Well done again. So, folks, thanks again for listening to this podcast. The show notes that's written by Maddie are available on the website Critical Care Education at www.critcareedu.com.au. Don't forget to listen to this podcast on iTunes, Spotify, or Stitcher. And we will see you in months' time again. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.